I'm going to talk about something a little different now. We've been talking about technology and advances, and I'm going to talk a little bit more about, first off, inhaled agents, because we've talked a lot about intravenous agents and titration and closing the loop, but also use inhaled anesthetic agents as a test case for a concept that I have not heard articulated ever, really, and that's the recycling of pharmaceuticals in general. So, I do have a couple of disclaimers. I have a company called Anesthetic Gas Reclamation, and we are proceeding with the long involved process, mostly a regulatory process, of trying to recycle volatile anesthetics. It has been a long and difficult road, and I'm sure will continue. Anytime you're breaking new ground, this is an issue. Our company does have a business relationship with Mindray involving anesthetic scavenging interfaces, the little piece that goes on the back of your machine so you can hook it up to your scavenging system. In general, and I'm going to move quickly through this because there's a lot of ground to cover, pharmaceuticals are increasingly expensive, shortages and supplies are uncertain, our environment is suffering because we are in part releasing pharmaceuticals into the environment, and we are moving from an era of relative plenty where physicians and healthcare can do anything they want at any cost to perhaps era of more economy. 13% in the U.S. of total healthcare expenditure is the cost of drugs. The cost of drugs is outrageous. $4,000 billion to develop a new drug in the U.S. And U.S. has monopoly pricing that produces regulatory concerns, quality concerns. Drugs really are the driver of the healthcare economy, at least in the U.S. We have had numerous shortages over the past few years, especially of generic drugs. Supplies are uncertain. Injectable drugs, almost 1 in 4 injectables have been in short supply. These are generic, produced by very few companies, and so periodic breakdowns, supply shortages are common. So the pharmaceutical world in general is in trouble. Very high cost, very irregular supplies, and we are very dependent on them. So these pharmaceuticals that we use on our patients have to go somewhere, and they end up primarily in the waste, in the air, in the water. There are numerous drugs that are detectable at greater than trace levels in the environment and wildlife, and volatile anesthetics, which is my area, contribute 6.5, and that's teragrams, million metric tons of CO2. Now, in the world view, that's less than 1%. It's about 1/10 of 1%. But still, it is a measurable and significant contribution to CO2 and potentially global warming. If you're going to try and recover any substance, whether it's paper, plastic, glass, drugs, whatever, you need to adhere to certain principles. One is to divide waste into as many separate streams as possible. Don't mix the glass and the plastic. Try and have a homogeneous waste stream. The other is to minimize dilution. If you're going to try and recover a bucket of paint, it is easier to recover it from a creek than if it's poured into a river. The economies of scale, trying to do things on a massive scale, are certainly easier than trying to do them selectively one at a time. And then really, in doing recycling and recovery, you should try and pursue things that produce the most value for the least effort. Go for the gold. I was told that that's why a famous American bank robber robbed banks, is that's where the gold was. BFI, a trash handling company in the U.S., has successfully adopted their corporate slogan of turning trash into gold. And they're making a lot of money by taking care of trash that no one else wants. My final principle is that engineering and hardware is the solution. If you put a trash bin or recycling bin, people will use it. If you make it possible so that the default direction that things go is toward a recycling stream, a waste stream, then people will do what's easy. If the recycling bin's not there, no, it goes in the regular rubbish. So, waste anesthetic gases, you may, I'm sure all know, are currently, depending on the country and depending on the system, scavenged by something like a vacuum system. Some negative pressure pulls the waste anesthetic gas away from the anesthesia machine. Sometimes, like in the U.S., this is combined with medical vacuum, and so these systems are often co-located or the same system, and so this vacuum pulls the waste anesthetic gas away. This was recommended as an occupational and environmental safety issue back in the 1970s. There was worry about surgeons falling asleep, nurses having miscarriages, and so the moving away, the scavenging of waste anesthetic gas was done for the health of the operating theater personnel. They use quite large vacuum pumps because these systems run continuously. They don't ever stop. Whether there's an anesthetic going on or not, these pumps are always running. And the waste is put out the roof of the hospital. Usually it's mixed with so much room air that you can go to the exhaust pipe and not even smell it, because it's down in the parts per million range. It's been mixed with 100 or 1,000-fold room air along with the anesthetic. We know now, but have only discovered in the last 10 years, that halogenated anesthetics, they are HFCs, hydrofluorocarbons. They are potent greenhouse gases, some of the most potent ones around. Desflurane has a global warming potential of 1,800 times that of CO2. Of all the other halogenated agents, CFCs, the spray cans, all those propellants have been changed. So anesthetics are a small part of this, but they're a rising proportion of the halogenated pollution that's occurring. Medicine's always gotten a pass because we're physicians, we do whatever we have to do. More and more attention's being focused on us now about why, again, exactly are you emitting these gases? So there have been publications in the last 10 years about climate effects, estimates of the amount of emission, estimates of the amount of harm that's done, but there hasn't been a lot said about what could be done. So this is an example of a vacuum pump in the basement of my hospital. It's the size of this table, it uses a huge amount of electricity, and it flows 2 cubic feet or 50 so liters per minute for each operating theater. It has to run continuously, 24 hours a day. It's quite expensive. And with older installations that are still running oil-based pumps, there's a risk of heat and fire because the gases it's exhausting have some oxygen enrichment. This was documented very well by a company called Beacon Medis, and that reference is still current. There are some approaches to trying to capture volatile anesthetics. We saw one earlier with the carbon or charcoal compounds. They absorb volatile anesthetics in a nonspecific way. There are also more specific adsorbents. One is marketed by a company called Blue Zone in Toronto, Canada, and it's a molecular sieve almost. It's a very specific absorbent for halogenated anesthetics. But once they're absorbed onto some solid substrate, what do you do with them there? They're not in the atmosphere, but they're still need to be disposed of or dealt with somehow. One other approach to turning anesthetic vapor back into some perhaps usable form is condensation. In fact, we had a great physics lecture here 30 minutes ago about moving the relative humidity to 100% by cooling the gas. If you cool room air that has, say, 1% anesthetic vapor to minus 100 degrees, the saturated vapor pressure, the amount of vapor that will stay in that, is less than 100 parts per million. That means all the remaining anesthetic will condense out as rain. So, one of the important things about condensation is that it works well in a rich vapor environment. If the anesthetic is diluted by 100-fold times by room air, it's like trying to make it rain in Arizona rather than in Florida. You need a high anesthetic humidity to make condensation work. So that's one important point. This is an ultra-cold freezer with a heat exchange coil running through it that's used to condense anesthetics. This is done on a pilot basis at our hospital, and we take the exhaust from 4 operating rooms, one suite that's on the same piping system, and bring the anesthetic through this cold trap and bring out the anesthetic vapor as a liquid. That's done with, I think it reads 95 below on the dial there, and the recovery rate is about 99%. So 99% of the vapor comes back as a liquid. To do that, we have to know things like saturated vapor pressures. If you look in handbooks of chemistry and physics, you can find the boiling points of sevoflurane and the vapor pressure at certain temperatures. What you can't find is any data below 0 degrees. So we actually had to create all the data and build vapor pressure curves all the way down. Everyone memorizes isoflurane 240 millimeters at 20 degrees. So we had to build it down to 100 below. The bottom curve actually is a curve of water ice. So water here and ice here, the vapor pressures at different temperatures. So this is, I think this is close to minus 100, and the log of the saturated vapor pressure. So this is 10 to the minus 2, 10 to the minus 3 for vapor pressures. If you think about an anesthetic waste stream, it contains things other than anesthetics. It also contains exhaled humidity. So that's why we had to do the calculation for water, because you're going to have a very humid stream coming out, and if you're not careful, the ice is going to clog up your condenser before you ever get to condensing the anesthetics. So if you apply these same principles of recycling to volatile anesthetic recovery, you should separate the waste streams. That means waste anesthetic and medical vacuum is separate. You should comply with EN 737, which is appropriate for Europe, but the US has not yet applied it. So part of my challenge is to have hospitals separate those two systems. 737 requires that medical suction and medical waste gas disposal be completely separate pipe systems. Minimize dilution, another principle of recycling. You want to capture the waste anesthetic, but you don't want room air coming into the system 24 hours a day. It just serves to dilute the anesthetic and make your recovery more difficult. You want to do this centrally on a suite or a hospital-wide basis rather than a single OR basis. And then there's possibility for a business case here, because sevoflurane still costs US $600 per liter. And if you recover it, the cost is quite low. There are obviously a lot of steps to go through. So you recognize a very old Ohio scavenger interface. This is the thing that allows the suction line to be connected to the anesthesia machine without injuring the patient. It has both a positive relief for high positive pressures and a negative pressure relief. The negative pressure relief is almost always open because this system is flowing and pulling room air in through this, and occasionally getting a slight dose of anesthetic from the anesthesia machine. We designed a demand-based scavenging interface that's really like a scuba valve, a demand valve. It only triggers and opens to vacuum when there's anesthetic present. It fills a reservoir bag, a small pressure sensor triggers a solenoid, it evacuates, but the system's turned off 95% of the time. So that conserves the hospital vacuum pumps from running so much. It also prevents the dilution of your waste stream by room air being entrained all nights, weekends, continuously when there's no anesthetic going on. So this is actually something that is in production in the US and on the market. And so it was a necessary but not sufficient step in order to do recycling. We needed to make the waste stream smaller. And as a side effect, we had some economic savings as well. The vacuum pumps don't need to be so big. They don't need to be replaced quite so often. And we had some data on this, and this is from a couple of years ago. Our scavengers were flowing 37 liters a minute before. Afterward, they were really flowing just the fresh gas flow plus the ventilator drive gas, because we use GE machines, and they, for God knows what reason, dump ventilator drive gas into the scavenging system, and that produces a little dilution, but we can deal with it. And so basically reduce the scavenger flows down to the equivalent of the fresh gas flow, and concentrated this waste stream from 0.1% SIVO. Now it's at really whatever the fresh gas flow was minus some dilution from the ventilator. So we are exhausting pure gas from the circuit with no additional dilution, no additional air entrainment. And that, as I said, produces some issues. There's a high humidity, there's a high FiO2, but there's nice, rich, vapor-rich anesthetic to possibly scavenge and process. So if you have this liquid anesthetic from your suite of ORs, you could do something with it. It's usually a mix of different volatile anesthetics, some water, some dirt, some trash, other things. One simple solution is fractional distillation, if you know the boiling points of these anesthetics. And I was fortunate enough to have Ted Eager look at this and say, well, of course it's simple. So that was reassuring to me. But the fact that the boiling points are different means you can bring off these anesthetics in a fractional distillation column one at a time. The one that we're most interested in, sevoflurane, the most versatile perhaps, comes off the column last. and what's left in the boiler is just a little water and some particulate matter. At the same time, as you know, distillation is molecule by molecule across over a hill to another container, and so we reduce bacterial contamination to almost zero by this distillation process. So that's a test case for taking a very pure single substance with no additives, no excipients, and trying to recover it from a waste stream. So it's probably the simplest case in pharmaceutical recycling. I used to own a large house and had many people come to do work on it. And I always wanted to have my revenge as a surgeon or anesthetist and stop in the middle of an operation and say, well, I'll be back in a week or so. Just it'll be fine. Yeah. So let's take this, and I've got 10 or 12 more minutes, and talk about a bigger recycling problem, pharmaceuticals and wastewater. Okay? We are told in the U.S. to throw away our used drugs into the toilet, into the sewage. If we take any medicine at all, some of these drugs and their metabolites are excreted via urine, okay? Active or not. The way our county and state and country organizes their handling of wastewater, there's no provision for this. This list I tried to paste in here. These are all potent opiates. The list goes off the bottom of the page, about 2 more pages down. All of these, we are told by our government, we must dispose of in the toilet. We must put these into our wastewater. Okay, all of them potent opiates. Fentanyl patch, Demerol, meperidine, methadone, morphine, fentanyl. That is the government-approved method so that they won't be diverted elsewhere. So all this is going into the sewer. Wastewater treatment plants, at least where I come from, remove solids, do some precipitation, they do some aeration, they do some kind of efforts to reduce bacterial counts, they add chlorine, use ultraviolet light, and then they're done. Any organic compound, any pharmaceutical passes through this process unchanged. So we saw what I showed you in the first few slides. There are 150 different drugs detectable in our rivers and streams and lakes. What if, and this is at the moment speculative, there was a way to apply those same principles of recycling to our wastewater? Everyone's smiling. We could separate the streams of waste, separate solid from liquid, minimize dilution. That means if you're really after a certain target waste stream, you don't want to add a bunch of extra water to it, so no more extra flushing. Use an economy of scale where this is collected centrally, stabilized, processed, however it might be. You want to go for high-value pharmaceuticals. These might be chemotherapy agents, steroids, opiates, antibiotics. And this can all be done with hardware where it's user-friendly and there's no real extra effort that anyone has to make. Let's look at urine for a moment. It has inorganic components, potassium, phosphate, chloride, sodium. Looks a lot like fertilizer, high nitrogen. It has some organics, urea, creatinine, some large complex drugs, and then some solids, some crystals and epithelial cells and a few things. Mostly not a lot of bacteria. Although urine itself is unstable, it decomposes, and that's why you see it get an ammonia smell if it sits for any length of time. There are other common constituents, and as you look, it gets quite complex once you start working your way down the list. You start getting steroids, imidazoles, various amino acids, along with things like bicarbonate and phosphorus. If you look at drugs of interest relative to creatinine, which is one of the most common constituents, we're down to 1 in 1,000, down to 1 in a million concentrations, which are not trace concentrations, they are substantial concentrations. And you can do the math and try and say, okay, how much could I extract from 1,000 gallons or 100 gallons? As an example, an effort to recover opiate drugs and keep them out of the waste stream might be flushing them all down the toilet, recover them undiluted, There are obviously regulatory issues. There are excreted metabolites that are active or easily made active. Morphine now is terribly cheap, so it's not cost effective to try and recover it. But what's the price of keeping it out of our water supply? Methotrexate was interesting. We actually had a shortage of methotrexate in the U.S. As a chemotherapy drug. It's excreted in the urine unchanged. Now, again, all this idea comes from, it's not a new idea. In the 1940s, penicillin was recovered in this same way. When it was an expensive drug and almost impossible to synthesize, it was recovered from the urine of experimental patients, reprocessed and used again. Since then, we've become so rich and wealthy, we've forgotten about some of these processes, so this isn't quite as outrageous as it might seem. So you'd need some infrastructure to do this. Maybe you set it up in a hospital to begin with because all those patients are excreting high-dollar drugs. So urine separation, no dilution, central collection, stabilization. I have my ideas about how that would happen. Separation of organic and inorganic components. The inorganic becomes fertilizer. The organic, now that you're down to a few grams out of many, many liters, is further processed. Isolation, purification. It would be interesting. As you see, the technology already exists. These are used primarily in European countries, although I'm seeing them now in the U.S. Urinals that have no flush because they have a trap that keeps any backflow or any smell from coming back. Toilets that have 2 compartments. Plumbing. This is actually from Stockholm. Talks about urine diversion and using urine as a source base for fertilizer. Doesn't talk about the drugs, but it talks about splitting these waste streams. And some regulatory requirements. In the U.S. now, gray water, which is water that's been used for washing but not, it still has some other uses, is plumbed separately. It's called purple pipe, and it's a third kind of plumbing that's done in addition to fresh water and sewage water, and so it can be used for certain applications. Perhaps I can invent a yellow pipe or some other alternative to one common sewage treatment. There is some issue about drugs, and I've alluded to this a little bit. The U.S. FDA is very strict about how it approaches drug approvals. It requires what's called traceability. That means every component needs to come from a specific source, and that manufacturer, that supplier has to have documentation of where all their components came from, and so on, so that if there's ever a problem, it can be traced back to one of the components, because regulation is, again, after all, about applying the blame properly in the right place. And then there is this issue of public acceptance. Okay, we breathe recycled air and we drink recycled water and we don't think about it. But when it gets a little more personal, we start to think too much. But clearly there are no engineering or scientific obstacles to be overcome in recycling anything. But other pressures. So hospitals can be equipped for recycling pharmaceuticals. It's easy for gases like waste anesthetics. We only have to separate the plumbing from the medical vacuum and try and make that waste stream as small and concentrated as possible. Liquid waste, there can be, and are already now for some chemotherapy patients, their urine and even their perspiration can be toxic, and so they're separated into separate containers. It's possible to plumb new hospitals so that this either source of toxicity or source of opportunity is diverted into a separate area. So I've given you a couple of outrageous ideas you might not have thought about. But some of the greatest progress comes from going to an area of your life where no one pays attention. For example, anesthetic scavenging. No one cares. It just goes away. I don't want it anymore. Send it away. Go there and you find opportunities for application of some common sense and some engineering. So you do indeed have to have a business plan if you're going to do this. So, is this a solution? It's quite complex to calculate the cost versus the benefit. The environmental costs could be enormous. There are costs of engineering, processing, infrastructure, public acceptance, even trying to get a recycled volatile anesthetic approved. The FDA's primary concern is, what will people think? So we're busy educating them as well as the public. And again, there are regulatory issues, and just in terms of inertia. Regulators exist to slow down innovation sometimes, but they also guard the public's welfare, and they have a job to do to try and ensure that our lives are safe. So, what we call life cycle analysis, when we look at the substance, a drug, anything that we do, we want to look at it from birth to death and then even afterward. And so what we've ignored is the death part of our pharmaceuticals. We have incredible opportunity to change people's lives and to heal people with amazing multi-million-dollar pharmaceuticals. Then we throw them away and ignore them. We don't look at their impact down the line. So distribution, disposal, environmental, abatement, all of that is part of the analysis that goes into any new process. So this is my favorite quote, which has kept me alive for the last 10 years. We're going to attach economic value to the elimination of waste. And then capitalists and innovators and investors will try and find that most precious thing. Find something that does good, helps the environment, for example, and at the same time makes a good business and makes a profit. Who could argue with that?
They can.
Thank you so much.